Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences at Keck Graduate Institute, and today we will be discussing multiple sclerosis. And the reason we're discussing multiple sclerosis today is though multiple sclerosis is relatively a rare disease state compared to many of the other disease states that you studied, multiple sclerosis still affects a significant amount of people. And unfortunately, with multiple sclerosis, there is not a cure, but there are many different non-pharmacologic and pharmacologic interventions that you can do to help treat multiple sclerosis. And as a pharmacist, it's important to be aware of both the non-pharm and pharm interventions that you can do to treat multiple sclerosis. Our objectives today will be to classify the different types of multiple sclerosis, to compare and contrast different treatment options for MS or multiple sclerosis, and assess pharmacological therapeutic agent selection considerations for MS. So we'll start off with a patient case. We have a 36-year-old female GT presenting to her physician for an annual checkup. She was diagnosed with multiple sclerosis or MS 3 years ago after her second multiple sclerosis flare in 2 months. Following her multiple sclerosis flares, GT had no other MS flares. Besides her 2 flares, she has had no other symptoms of multiple sclerosis. Which type of multiple sclerosis does GT most likely have? Relapsing remitting, secondary progressive, primary progressive, or progressive relapsing? GT's multiple sclerosis has never been considered aggressive or rapidly evolving by her physician. Which of the following agents may GT most likely be on considering her disease course? Alemtuzumab or Lemtrada, Dimethyl Fumarate or Tecfidera, methylprednisolone, Salumedrol, or Natalizumab, Tysabri? And the third question we have is, which of the following agents may cause the patient to have bradycardia and AV block, requiring monitoring of the heart or cardiac monitoring after the first dose is administered? Alemtuzumab, Lemtrada, dimethyl fumarate, Tecfidera, Fingolimod, Gilenya, or Natalizumab, Tysabri. So after today's lecture, you should be able to answer each of these questions with relative confidence. We're going to go a little bit now into the background of multiple sclerosis. So what is multiple sclerosis? Multiple sclerosis is an inflammatory disease of the central nervous system. And it is essentially a destruction of myelin and axons. Myelin, if you remember from basic pathophysiology, is the protective material that basically surrounds the neuron and protects the neuron from any damage that occurs. If you destroy the myelin, then that neuron is not necessarily protected. An axon is essentially a large part of that neuron, and that axon is no longer necessarily protected from the myelin. In terms of just the name multiple sclerosis, multiple obviously means the number or amount of damage that you actually have. So usually you have to have multiple lesions or multiple sites of destruction in the central nervous system. A lot of times we'll see this in the spinal cord area and sometimes even in the brain. Sclerosis means demyelinating lesions or plaques. And whenever we get to one of the future slides later on in the presentation, you'll actually see how those actually look within the CNS. So multiple, you have to have a number of them, and you have to basically have demyelinated lesions or plaques. That's basically a couple of the main diagnostic criteria. In terms of epidemiology, it does not really affect a whole lot of people relatively compared to a lot of the other disease states that you see. Only about around 250 to 350,000 Americans have MS, and that only about 2.3 million people worldwide, and obviously that number grows as population grows. Diagnosis often occurs around younger ages between 20 and 50 years old. It disproportionately affects women more than men in an approximately 2-to-1 ratio, and North American descent actually has the highest risk of developing MS. And we'll show you a little bit, about what the theories are behind that. One important point about multiple sclerosis is that 50% of patients will need assistance walking within 15 years of disease onset. And you see this little lady here. A lot of patients, may eventually have a worsening of symptoms and may actually require, walking assistance like a cane, a wheelchair. They might have a certain degree of paralysis that happens or spasticity. Where they're not able to actually function properly and do their normal activities of daily living. And it not only just affects just the ability of the patient to walk, it also affects their other systems as well, such as their brain and their and the potential to have psychological disorders. So a lot of the psych disorders that we see may be a result, potentially, of multiple sclerosis. They might, have different psychological disturbances as a result of their underlying MS. Vision problems, like we said, motor disorders, but they also might have other things like bladder disturbances, urinary incontinence, and sexual dysfunction as well. And that's actually kind of what's detailed in the little writing that's here if you look really closely. In terms of epidemiology, as we had mentioned before, as you see the map here, the map is very color-coded, with the red areas being the actual risk of developing multiple sclerosis. And you see here that basically North America is probably the most red area on the map. There are some areas here in Europe as well as in Australia and New Zealand that also have potentially a little bit of a higher risk. And there are some theories about why this is compared to other areas such as South America, Africa, and other parts of Asia that don't have as high a risk, particularly South Asia. So like I said, it's not necessarily known about what is going on in terms of MS. There are some theories about a combination of a genetic factor and a non-genetic trigger. So it's thought that you might have to have multiple things in order to generate an eventual diagnosis of MS. So basically something within a patient and then something that a patient may potentially be exposed to. Or something that is basically, potentially infected by the environment somehow. So that could be a virus of some type. Metabolism, while there are some genetic factors within metabolism, you still basically, do influence your metabolism a significant amount by, how much and what type of foods that you eat, in addition to, the way that you go about your normal activities of daily living, exercise being a very important thing in generating metabolism. So it's not necessarily known how much of a role those things have, but those things can obviously play a role in altering metabolism and potentially even a role in MS, but it's not really, very well known. There are also potentially environmental factors that play a role in this. And you saw from the map on the previous slide that, only certain areas are affected. So what do these areas have that, predispose someone to developing MS? It's not really known. But we do know that there might be something potentially there that might predispose a patient to developing this type of disease state. And that's basically where, a lot of research, still lies ahead. How is this actually caused? And, if we can figure out the specific causes of, why this phenomenon is occurring, maybe we can actually treat it more appropriately. Because a lot of the drugs that you're going to see and a lot of the therapies that you're going to see, non-pharm and pharm, obviously don't cure MS, but they can obviously improve the life of a patient that has MS, minimizing the related symptoms that they have with MS, reducing the amount of flares, improving, things like walking speed, or reducing the overall quality of life. So this illustration here kind of just gives you a little bit of an idea of what the brain looks like. and basically the CNS. So as you see here on the bottom portion, this is a coronal brain view of what you would see potentially on a radiographic scan. And you see here in a healthy brain that this looks relatively symmetrical. You have white matter, gray matter, and the ventricles within the brain. Whenever you have MS, though, you actually have demyelination of some of this tissue here. And this demyelination is shown as the little red marks within the area. And obviously, because this is demyelination, demyelination doesn't always discriminate in terms of symmetry. So you might have certain parts of the brain or certain parts of the spinal cord that may basically demyelinate first, depending on whatever is at highest risk or wherever the MS decides to basically attack. It's basically almost an autoimmune disorder in a sense. Basically, it's like your immune system is basically fighting the rest of your body and basically causing this destruction to occur. So you have relapsing remitting disease, and you also have progressive disease, and you see different changes here. I'm not necessarily concerned about you knowing about the specific brain changes or the specific spinal cord changes that can occur. All I kind of want you to get from this slide is that this is basically what healthy CNS looks like, healthy spinal cord and healthy brain. And in MS, there's basically alterations that occur. And they can occur within the brain and or the spinal cord. And, eventually they can increase over time. You might develop, a lesion or a few lesions at the beginning. And then you might eventually, have many more lesions than you actually had before with, further worsening of the disease process. So risk factors. Family history is always something we want to note, and it's even beyond potentially just first-degree relatives. So this would be kind of a special exception to the typical rule of let's look at if your siblings have it, if your mom or dad has it, or if any of your offspring like sons or daughters have it. This might be something that may pop up in weird places in family lines. Obviously, if a patient has other history of other autoimmune diseases, and autoimmune diseases are relatively rare, but they do happen from time to time. Additionally, if a patient has migraines, that might, predispose a patient or may be a potential risk factor for an eventual diagnosis of MS, because a lot of these patients do tend to have headaches a lot. Like we mentioned before, autoimmune disease is important to note, migraines, and then cigarette smoke exposure is another thing that is potentially a risk factor. It's one of those environmental factors that might be out there that might actually predispose someone to MS, though there's no necessarily one particular thing that defines MS or a risk factor for MS, so that's important to note. So how do we classify MS? And how do we basically go about diagnosing it? So first off, we need to understand kind of the disease process about how it presents, and then we can kind of go into how it is diagnosed. And the diagnosis is a little bit on the complicated side. But what I do want you to kind of get from this is being able to distinguish between the different types of MS that we have, because that is sometimes going to dictate what therapy we can actually give someone. And that's pretty important whenever we're picking drugs. With secondary progressive MS or SPMS, this can develop, and this was kind of what I was alluding to in the last slide, this may actually develop in patients with relapsing remitting MS or RRMS. So what happens here with secondary progressive is that a lot of times patients with RRMS, and this doesn't happen very often, but basically patient may be diagnosed with RRMS, but then the disease course just worsens with or without remission periods or leveling off of symptoms in terms of the symptom severity. Basically, you might not necessarily have plateaus of leveling off of symptoms. The disease course will worsen. That's basically where the progressive name comes in. Progressive means worsening. Secondary means that there's already a diagnosis there in terms of the MS. So basically something has already happened. Or something has basically already been identified. This is uncommonly diagnosed, though. This is very, very few patients actually having secondary progressive MS. So just keep that in the back of your mind. It's uncommonly diagnosed. It's probably really difficult to diagnose in regards to the other types of MS, like RRMS, which is relatively common. Primary progressive MS. This affects about 10% of patients with MS. So this is kind of the second leading type of MS. What happens with primary progressive MS is that from the beginning, symptoms, worsen immediately from the beginning. And there's no necessarily relapses or remission. They just generally get worse over time. They're not going to have, severe episodes of exacerbations, relapses, severe episodes of just like, big MS flares where they're, becoming like really spastic. You may occasionally have a plateau of symptoms that occur where the symptoms basically kind of level off but stay steady. But overall, the course of this type of MS is not that great. And one thing to note is that primary progressive MS is very resistant to drug treatment, but we do have a medication that is approved now for primary progressive MS, which we'll talk about a little later. Progressive-relapsing MS, or PPMS, is also relatively rare. It affects about 5% of MS patients, so basically kind of the third most common of the four. It is progressive from the beginning, but like the name says, you do have intermittent moments of relapse where you might have worsening set of symptoms, worsening spasticity, worsening, psychological effects, worsening sexual side effects, worsening vision changes, etc. In progressive relapsing MS, there are no periods of remission. Again, with progressive nature, that means basically if it's going to get worse, it's not going to get better. So keep in mind these key words as you basically think through the disease process, because that will dictate a lot of times the type of MS that the patient will actually have. And that will be very important for exam purposes, hint, hint, star, star. Clinical presentation. So like we alluded to earlier, MS obviously affects multiple different systems. Not just the brain and the spinal cord, but a little bit of everything. Because remember, our brain and spinal cord send messages to the rest of our body and innervate a lot of the rest of our body in regards to communication. So obviously, big things that we have issues with are motor disorders. So we might see moderate to severe spasticity in the legs, dysesthesias, ataxia. We may see sensory disturbances where they're not able to see. They might have vision problems. They might, develop things such as double vision or diplopia, which could obviously be problematic if they are, doing activities such as driving. Doesn't necessarily mean that an MS patient can't drive, but if they start developing these symptoms, that might be a signal that it might be time to unfortunately take the license away. Similar to like what they would do in a patient with epilepsy. We also potentially may see vertigo in these patients. They may become very dizzy, and that's obviously due to the CNS effects. You might see bladder disturbances. You might have patients with urinary incontinence as a result of MS. And remember that, like I said before, your CNS innervates everything. And bladder is no exception to that. You might have unilateral numbness affecting one leg. You might have it in both legs. You might have neuralgias, optic neuritis, or basically an inflammation of the optic nerve. A lot of patients actually have lots of bowel issues like constipation. And again, remember, everything is innervated by the brain and spinal cord. They are innervated by neurons and action potentials. So the gut is one of those things, unfortunately. So, if you get constipated, obviously you want to, check other underlying causes, but if it's MS, that's the underlying cause, you can't obviously, treat that. And you might have to give them, medications to treat their constipation, depending on the type of constipation and, the patient themselves of what their demographics are. So you might see a lot of these patients on a lot of different laxative medications. Patients may become tired. Obviously, they already have a lot of motor neuron disturbances and, demyelination that's happening, and that's obviously destroying their brain and spinal cord, and it's going to cause, fatigue. Sexual dysfunction. Some of these people might develop, decreased libido. They might, suffer from ejaculatory problems if they if they are male. Women may suffer from vaginal dryness, pain during sexual intercourse, and may not be comfortable to have sexual intercourse. And that's just something that, is, what an underlying problem with the disease state is. It affects everything because neurons are everywhere. Psychiatric disturbances, obviously a big problem. If it affects the brain, it's going to potentially cause psychiatric disturbances. And you can try to treat these with drugs, but ultimately, there's not necessarily, something that's going to, always help better than the other thing. Remember that these, psychiatric disturbances that you're going to be seeing with patients with MS are secondary to the MS a lot of times. And, obviously, if you want to fix the underlying problem, in this case, you can at this time because we don't have a cure. So you might be able to, use different medications for patients, and they might have, great response or moderate response, but it may not always be like that as the disease state worsens over time, or if they develop additional lesions in the CNS. So how do we go about diagnosing MS? There's no single diagnostic test. Like we mentioned before, you need to have multiple areas that are damaged in the CNS or the central nervous system. So that includes the brain and the spinal cord. You want to determine that the damage has occurred at least 1 month apart in terms of the damages, if that's possible. Sometimes the timing might just not work out, and that really requires an advanced and specialized neurologist to be able to detect whether or not something can be MS. Usually, though, with MS, this is what's known as a diagnosis of exclusion. So usually whenever a doctor is working up a patient for these type of symptoms, they're going to start thinking about other things first because, like we said, MS is not very common. And whenever you are working up a patient or a physician is working up a patient, they're going to try to go through the things that it's going to most likely be first. And they might, find a diagnosis that fits all the symptoms. And these patients might actually, go to multiple physicians before they actually get a, accurate diagnosis of multiple sclerosis, if they actually do have multiple sclerosis. And that can be problematic, obviously. It can, obviously cause a lot of strife with patients, cause a lot of issues. And, that's just kind of the way, unfortunately, that the cookie crumbles, because sometimes we might not always think, of MS as like basically, the diagnosis to make initially whenever a patient presents, with some of these types of symptoms. They need to typically observe the symptoms for at least more than 24 hours. And again, episodes separated by at least 1 month. MRI can be used to basically look at the presence of different lesions. And remember, we need to have at least 2 lesions. You can also do a spinal tap. And this is basically to examine for oligoclonal bands, which are typically seen in patients with MS. Again, you want to exclude all other possible diagnoses first. This is usually a diagnosis of exclusion. It's not typically the first, second, or third thing that is going to be on a patient's or a physician's mind to diagnose the patient with initially. So always keep that in the back of your mind. The disease progression. It depends. The disease progression really depends on what type of MS that you have. You might have obviously different types of MS that are occurring, and you might have a pre-symptomatic phase where these lesions are just starting to form and they don't necessarily have done enough damage at a point to actually cause MS. There is something that's called clinically isolated syndrome, and usually this is basically in some cases a patient's first potential way to actually detect MS. And that basically, what you need to know about clinically isolated syndrome is basically they might have had an episode, or they might have had some type of set of symptoms, or one symptom that was kind of a one-off thing in the early phase of their actual disease. And basically that might be the first sign that they might have something, but they might not know about it until much later, as you see as this disease course basically progresses and basically the patient becomes potentially more disabled over time. So what are our goals of therapy with MS? We want to prevent permanent neurological damage. We want to decrease any relapse incidence. So if a patient is having lots of relapses or exacerbations of their MS symptoms, we want to try to minimize that when possible. And a lot of our drugs do a decent job of doing this, but they're not going to necessarily stop all relapses. And you'll see here that some of the best drugs are only about 55 to 60% good at decreasing relapses. And in MS, if you can even decrease one relapse from happening, a lot of patients will be thankful for that. But that's not necessarily always good enough, though. We want to try to make sure that we can minimize as much of this as possible. We want to avoid disability if possible. We don't want patients to progress, to the point where they need a cane or a wheelchair if they were perfectly functioning before. We want to make sure that their quality of life is maximized, because as you see, MS can affect many different organ systems, can cause many different symptoms to occur in different places in the body, and we want to try to make sure that the patient can, if possible, still perform their activities of daily living, and basically have any minimization of symptoms that can be minimized where possible. Though, as we said before, a lot of these symptoms, while they can be minimized, as the disease gets worse, they might not necessarily be able to be treated as well as they did earlier in the disease course. So what are our first-line treatments? And I'm going to preface this slide by basically saying that there's no necessarily perfect guideline for MS. There are guidelines out there in the United States as well as Europe regarding MS, and there have been articles that are out there that recommend first and second line treatments. Now, whenever you're determining first and second line treatments, you really have to make a determination with the patient about, what are their goals of therapy? Do they want to take something that's oral? Are they okay taking something that's parenteral or IV or sub-Q? What are the risk factors with each individual drug? And you might have to consider those things whenever you are, potentially even making a recommendation about what drug to recommend for the patient. So, in general, a lot of times the first line treatments, and these are treatments for relatively more mild to moderate cases, are dimethyl fumarate or Tecfidera, Teriflunomide or Aubagio, Interferon Beta, Avonex, Plegridy, Betaseron, Extavia or Rebif, and then glatiramer acetate Copaxone. So we'll start with dimethyl fumarate or Tecfidera. For the purposes of this talk today, you're not going to necessarily need to understand the mechanism of action. A lot of these drugs are not fully necessarily understood of how they work. Some of them, the net effect is known, but it might not necessarily always be known about how it induces that effect. The things that I really want you to focus on today are basically how are they provided in terms of route. Basically, what are some of the adverse effects of some of these medications, and what are the considerations that we need to make regarding these medications. So route, adverse effects, contraindications, special facts. Anything that's special about the drug is obviously going to need to be noted. And obviously, brand names are listed here, and brand names are important to know because if a physician comes up to you and asks, what do you think about Tecfidera for this patient, you're going to need to know what that drug actually is. So brand names are fair game for the exam, hence star. So dimethyl fumarate or Tecfidera induces expression of anti-inflammatory proteins. It is available PO. This actually is one of the a really relatively good medication for MS. Its reduction in clinical relapse rate is actually decent compared to a lot of the other drugs that you're going to see. It's 50%. Some of the other drugs are in the 30s and 40 percentile. This one actually produces about 50%, which is actually pretty decent. In terms of adverse effects with Tecfidera specifically, some of the problem with this medication is basically some of the simple side effects like flushing. And, a lot of times, this can be something that kind of wears off over time. But in general, though, some patients may experience this, and that can actually be treated with aspirin, 325 milligrams, 30 minutes prior. Other things that you might see with Tecfidera, which are relatively common for most medications, are abdominal pain, nausea, vomiting, diarrhea. You see those with almost every single medication that's out there. A lot of the MS medications also have lymphopenia that basically is a side effect of most of these medications. A lot of these medications will actually deplete lymphocytes. Because one of the thoughts about an autoimmune disease is that the immune system is basically attacking the rest of the body, or in this case the CNS. So if you're depleting lymphocytes, technically that can be a good thing to an extent, but if you're depleting too many of them, that can obviously weaken your immune system, and that's something that we want to watch out for. Hepatotoxicity is a problem. With a lot of these medications, they can damage the liver. And then additionally, progressive multifocal leukoencephalopathy, or PML, is a problem with this medication as well as some of the other medications. And I do want you to be aware about the certain medications that cause PML. PML is basically a type of brain infection that can occur, and that can actually occur as a result of taking a lot of different MS medications. While it is relatively rare, it can happen, and it actually is a black box warning for several different MS medications, one of them being Natalizumab or Tysabri, which we'll talk about a little bit later, and it actually has its own REMS program in regards to that. Teriflunomide or Aubagio is another medication. This is actually a chemotherapy agent. It's a pyrimidine synthesis inhibitor, reduces B and T cell activation, function, and proliferation. It's available orally. It does reduce the clinical relapse rate by about 30%, so not as good as dimethyl fumarate or Tecfidera. Adverse effects include nausea, vomiting, diarrhea, hepatotoxicity, electrolyte disturbances, renal failure, SJS and TEN, alopecia. This is a chemotherapy agent that is used for cancer. So like a lot of the chemotherapy agents, this one does cause loss of hair, and neutropenia and leukopenia. Some considerations with teriflunomide is that it is contraindicated in pregnancy, so you might be very cognizant of that, particularly with some of these medications. With females of childbearing age, you want to obviously screen for pregnancy prior to therapy start. And if having a family is important to a patient, you might not want to start this in a female who is of childbearing age. You want to screen for tuberculosis prior to this therapy. A lot of these therapies will cause immunosuppression, obviously, because of the reduction of the B and T lymphocytes. And that can obviously be a big problem. And whenever you are immunosuppressed, you are at more risk of developing tuberculosis. Another big thing with a lot of these medications is that it's important that you don't administer live vaccinations with teriflunomide. If you administer a live vaccination to a patient who are on some of these drugs, you might have actual activation of potentially what you're vaccinating really against. So you want to be cognizant of that, because if your immune system is not fully functional, like it would be for a normal patient who's not on these drugs, and you administer a live vaccination, that obviously puts them at risk of activation of whatever you're vaccinating them with, or a reactivation if they've already had that specific disease state previously. Interferon Beta. There are many different brand names of this one. The one that we'll just focus on for our purposes is Rebif. But you might see any of these names, so just be cognizant of that. Rebif is the only one I kind of want you to focus on, though, for just the purpose of this talk today. So this one actually has a lot of different anti-inflammatory and immune modulating mechanisms. It is available IM or sub-Q. The dosing obviously varies depending on the formulation. This one also has about 30 to 35% reduction in relapse rate versus teriflunomide, which has about 30%. Obviously, with interferon beta, because it is IM or sub-Q, depending on the formulation, you might see injection site reactions. You might see flu-like symptoms occur. One big one that is unique to interferon formulations, for the most part in general, is that you might see depression or suicidal ideation. So if a patient has a history of depression or suicidal ideation, this might not necessarily be the best agent for that patient. Hepatotoxicity, another problem, and lymphopenia and leukopenia, as we've mentioned with a lot of the other agents so far. Glatiramer acetate, Paxone or Glatopa. Suppresses T cell activation, induction, and activation of suppressor T cells. This one's available sub-Q. You see the dosing here can be daily or 3 times a week. It's about, it will reduce relapse rate by about 30%. Adverse effects, obviously injection site reactions, a big, potential problem. Specifically with post-injection, you might see patients develop flushing, chest pain, palpitations, or dyspnea. If that is the case, I would, be inclined to send them to the emergency department, because obviously anytime you have chest pain, that's not a good sign. You obviously want to get that checked out and evaluated a little bit further, and obviously that can be ineffective in this specific injection. Menstrual disorders can be a problem with this medication in female patients, urinary tract infections, and then again leukopenia. Again, this one's another one where you don't want to administer live vaccinations while on therapy. Now that we talked about the primary first-line treatments, we're going to now talk about the general second-line treatments. And again, this is not necessarily a hard and fast thing. Again, the decision has to be made in conjunction with the patient about what is best to start first line, or what should a patient transition to if they fail a first-line therapy or another therapy. And this list also includes initial therapy for a poor presentation. So if they, are presenting very poorly as determined by the physician, and a lot of times it will be a neurologist who is basically making the call on this, then in that case, you can actually go to basically this list of medications to start. And the options that we have here are Natalizumab or Tysabri, Fingolimod or Gilenya, Alemtuzumab or Lemtrada, Ocrelizumab, Ocrevus. And then we also have some of our first-line agents like Dimethyl Fumarate, which we said is relatively good in terms of relapse rate. And then Teriflunomide is also one that's been mentioned in the literature that you could potentially recommend as a second line or a switchover therapy. Again, this is not a hard and fast list. This is a list that's been seen in a variety of different review articles, text. Again, this is not hard and fast. And for testing purposes, there will be one best answer for each case scenario if I tell you to choose a therapy for a patient. So keep that in the back of your mind. You obviously want to be aware of the patient's individual limitations, if they can only take oral, or if they can't take oral medications, if they have something in terms of disease states that's bad, or basically can be caused by a medication. That might be something that you need to kind of weigh with the patient. Natalizumab or Tysabri. So this one is one of the bigger guns, as I would call it, for MS. It's a recombinant humanized monoclonal antibody, and it prevents leukocyte migration across the blood-brain barrier. This one's available IV. Its dosing is typically 300 milligrams IV every 4 weeks. This is not indefinite. They may give this for a relatively short time, obviously due to the potential side effects and the fact that it is a closely monitored drug. Its reduction in clinical relapse rate is fantastic, 68%. That is very high for multiple sclerosis. And I know you're probably thinking, Dr. Broussard, 68%, that's still failing. But for MS, that is a passing score. Like we said before, some of these drugs only have 30% clinical relapse rate. Adverse effects. So headache, fatigue, arthralgia, depression, infections. The big one, though, that we want to focus on here is PML, and that's progressive multifocal leukoencephalopathy. This particular adverse effect is the REMS monitored adverse effect for natalizumab for use in MS. Now, in regards to REMS is risk evaluation and mitigation strategies. These are special programs that basically require the prescriber of the drug, as well as basically whoever is dispensing the drug, to basically be registered. So the prescriber and the actual pharmacy have to be registered. So a lot of times you might only be able to get some of these drugs either at specialty pharmacies or at specialty home infusion clinics. And as a result of it being an IV administration, this is obviously something that you would not administer probably in a home setting. You might do it as a in a home infusion setting, or you might do it potentially at a setting that basically has an infusion suite. That's important to note here. In regards to REMS, though, with the PML, one thing that they require for this adverse effect is that the patient obviously be screened for risk factors for PML. And one thing that they found with risk factors for PML is that patients may develop patients who are at risk for PML may have what are known as anti-JCV antibodies. And JCV is also known as John Cunningham virus. It's a particular type of infection that can, potentially happen or be a risk factor for developing PML. So usually what will happen is if they want to start a patient on natalizumab or Tysabri, they're going to screen for these anti-JCV antibodies. And if they are positive for anti-JCV antibodies, that is usually an exclusion criteria for giving natalizumab. They don't want to put the patient at risk for developing PML because anti-JCV antibodies are a risk factor. Additionally, we don't want to administer live vaccines while we're on this therapy, obviously. It's very immunosuppressive. Not obviously great to administer a live vaccination. Fingolimod is the next agent that we'll talk about, and we actually now have analogs of fingolimod that are now, out on the market. It is a sphingosine 1-phosphate receptor modulator, and it prevents lymphocyte exiting from the lymph nodes. So if you prevent lymphocyte exiting from the lymph nodes, those lymphocytes cannot attack necessarily the rest of the brain and spinal cord. This agent is available PO. You see the dosing is there. This one is relatively good at reducing clinical relapse rate as well as 55%. Some of the things that are unique for fingolimod is that it does have a lot of cardiac related adverse effects, and that's actually what is basically monitored for the REMS program. It can cause bradycardia or AV block. So typically whenever this agent is started, a lot of times the patient will have to be monitored for at least 6 hours after their first dose, because they might develop bradycardia or AV block, and obviously that could be a big issue, particularly if the heart rate goes too low, or if they obviously develop AV block or another type of arrhythmia that can occur. And obviously you see a lot of contraindications here, which we'll get to in a moment. Transaminase elevations, and that can obviously predispose a patient to developing hepatotoxicity, headache, decreased pulmonary function, hypersensitivity reactions, severe viral and fungal infections. Obviously a lot of these things are immunosuppressive. Lots of infections can happen. PML and malignancies also. PML popping up again here. This is not necessarily one that has a high risk of PML developing as high as Natalizumab or Tysabri. Considerations here is that it is contraindicated in patients who have myocardial infarction history, unstable angina, stroke, TIA, decompensated heart failure, a Mobitz type 2 second or third degree AV block type of arrhythmia, essentially. Sick sinus syndrome, that's essentially a type of syndrome where patients actually can become very bradycardic or very tachycardic as a result of alterations in the SA node in the heart. Prolonged QT, basically greater than 500 seconds for QTC. Concurrent use of a 1A or 3 antiarrhythmics. So obviously we want to, with all of these potential complications, obtain a baseline EKG for these patients at minimum, and obviously monitor the patient. This one is also a REMS monitored medication, so it's very closely monitored. Prescriber and pharmacy have to be registered. Not something that you're going to routinely dispense at your local community pharmacy. It has to be at a place that is registered. So we don't administer live vaccinations while on this therapy either, obviously higher risk. Alemtuzumab or Lemtrada is a humanized monoclonal antibody directed against CD52. This causes rapid depletion of the CD52 positive B and T cells. This one is available IV. It has a very specific regimen associated with it that you see here. It's given for 5 days, once a day, and then followed in a year by an additional 3-day regimen. Some of these, medications are given only for a few times once a year, and you're done. I will, defer you to the package inserts and the appropriate literature regarding some of the dosing regimens on these medications, because they can be very complicated, especially if you want to consider some of these things to be given again. Reduction in clinical relapse rate, relatively good for this drug, also 50 to 55%. Obviously, because it is IV, you can see infusion-related reactions. With this one, specifically nasopharyngitis, autoimmune disorders. Like the rest of them, infections and malignancies are a problem here. Thyroid disease and pneumonitis. Considerations, this one also has its own REMS program. The reason why it has its own REMS program is for autoimmunity reasons, so it might result in patients developing autoimmune disorders. Infusion-related reactions can be a problem with this particular medication, as well as malignancy risk. So you always want to keep those things in mind with this particular medication. It is very, cytotoxic. With this medication, we typically will pre-medicate patients with corticosteroids, acetaminophen, and oral antihistamine for the infusion-related reactions. It is contraindicated in patients who have human immunodeficiency virus or HIV, AIDS, and also TB per the Canadian labeling if you ever go practice in Canada. So obviously you want to screen for HIV prior to this therapy. We don't want to worsen a patient's HIV status. We also don't want to administer live vaccinations while on this one either. Ocrelizumab. It is a humanized monoclonal antibody directed against CD20 or B lymphocytes. This one actually came out about 3 to 4 years ago. It is it is the only one that is approved for primary progressive multiple sclerosis. Remember, we talked about primary progressive is very resistant to drug therapy, and Ocrelizumab or Ocrevus is the one drug that is approved for PPMS. So that's an important point to note. Hint, hint, star, star. Dosing on this one is 300 milligrams IV on day 1, 300 milligrams IV 2 weeks later, and then 600 milligrams IV 6 months later. Typically, you'll get this in an infusion-related setting. Adverse effects, respiratory tract infections and other infections, obviously, immunosuppressive agent, infusion-related reactions because it is IV, depression and back pain. Some considerations that we want to think about here. Ocrelizumab is an analog or very similar to another drug called Rituximab, and we're going to talk about Rituximab or Rituxan a little bit later. But it is contraindicated in active hepatitis B. So we do want to screen for Hep B prior to therapy. Because it is very immunosuppressive, it can actually cause reactivation of hepatitis B if hepatitis B goes latent. We want to pre-medicate with steroids such as methylprednisolone and an antihistamine such as Benadryl. We also may give acetaminophen for the infusion-related reactions related to this medication. For Ocrelizumab, we do not want to administer live vaccinations while on this therapy and until the B cells are repleted. So basically, since it does basically work against B lymphocytes, we don't want to give any live vaccinations until those B cells are restored after Ocrelizumab usage. So now we talked about the general first and second line therapies that you typically see with MS, but there are a lot more medications that can be used, and there are specific reasons why you may or may not use some of these. Some of these are just, so new that they don't really have a place in therapy, and some of these are off-label completely in regards to basically treatment of MS. So obviously, as we talked about, MS is a very complicated disease state. Some patients may not respond to certain therapies. And, whenever, they were refractory to, certain things, it's a conversation between the physician and the patient in regards to, well, do you want to try anything else? And sometimes, some of these medications may be on that type of consideration list. So as you see the list here, we'll talk about all of these different therapies. Corticosteroids are the first one. The main thing that corticosteroids do for MS is they prevent or potentially prevent inflammatory cytokine activation, inhibition of T and B cell activation, and prevent immune cells from entering the CNS. Question mark on that one. It's not fully understood how steroids necessarily work. Obviously, steroids, as you're very well aware, are available intravenously or IV and PO. These are typically reserved for acute MS relapses and MS flares. So anytime you have an exacerbation or an active exacerbation going on, steroids are what we want to give. and you see that bolded here. It's very important to note. You see the dosing here is very high for methylprednisolone. You're probably used to seeing a lot of times in your community pharmacies medical dose packs, which are only about 4 milligrams in terms of the tablets, and they may be given 6 tablets in one day, which is only 24 milligrams. We're giving 500 to 1250 milligrams of methylprednisolone daily. And sometimes it might be even higher than that, depending on individual prescribing patterns. And it's given you relatively high dose for a short course. You also might continue steroids for a short course or even chronically on the outpatient side if patients continually have lots of MS flares. That can be potentially done kind of off-label or off-guideline practice, and that could be potentially fine for a patient if it works for them. Some adverse effects, I know you have talked previously in the endocrine course about some of these, but I'm just listing some of the general ones. But there are obviously many more. GI upset is, something to worry about. Insomnia, don't take it close to bedtime. Mood disturbances can cause delirium, and hyperglycemia, in addition to other metabolic disturbances like hyperlipidemia, hypertension. Additionally, if chronically used, osteoporosis. Dalfampridine. This one does not reduce the clinical relapse rate. The only reason dalfampridine is used in MS is to improve walking speed. It is a potassium channel antagonist. It is available orally. You can give it 10 milligrams PO twice a day. Adverse effects, the big one that is focused on primarily is incidence of seizures with this medication. And it's potentially even problematic in patients who have seizure disorders or a low creatinine clearance, because this medication is eliminated renally. So that is important to note here with this medication, enhanced or STAR. We may see seizures, UTIs, insomnia, dizziness, back pain, balance disorders. And balance disorders may be as a result of the drug, but it also may be a result of, obviously, the disease process. And that's something that we just have to keep in mind. But again, with this drug, does not reduce the clinical relapse rate. So this is just basically for symptoms only. If you have problems in terms of walking, or if you want to try to preserve what ability to walk that the patient has left, this might be a consideration. But obviously, because it does cause seizures, it's contraindicated in seizure disorders, and we don't want to give it to anyone with a very poor creatinine clearance. Rituximab or Rituxan. This one is a medication that is used for chemotherapy and is one of those, magical wonder drugs that you see for a variety of different indications. It is a chimeric murine human monoclonal antibody directed against CD20, so it's similar to Ocrelizumab. This one was actually obviously available before Ocrelizumab was available. Rituxan has been around for a long time. And it can regulate cell cycle initiation and differentiation. It is available IV. Rituxan or Rituximab can be given every couple of weeks annually, or given weekly times 4 doses. Dosing regimens will vary depending on what resources you look at. Adverse effects, obviously, if it's given parenterally, infusion-related reactions are a problem. Infections, and then the PML is also another issue here. With the CD20 inhibitors, screen for hepatitis B prior to therapy start can cause a reactivation of latent hepatitis B into active hepatitis B. We do want to medicate beforehand with acetaminophen and antihistamine. You may even potentially consider a steroid beforehand also. And we don't want to administer live vaccinations while on therapy. Ofatumumab or Kesimpta. This one is a very, very new agent. This is actually one of the first agents that's actually sub-Q against CD20. Or basically B lymphocytes. It's a human monoclonal antibody, and you see here it is sub-Q. It is FDA approved for RRMS and active secondary progressive disease. The dosing of this medication can be given 20 milligrams administered at weeks 0, 1, and 2. So obviously weekly, and then you can give it monthly starting on week 4. So not too often that you actually have to actually give it. Similar to the other CD20 inhibitors like Rituxan and Ocrelizumab, respiratory tract infections, other infections, injection-related reactions, and headache are problems with Kesimpta. Considerations: contraindicated in Hep B. You want to pre-medicate with, this you might want to pre-medicate with this medication, particularly potentially with IV steroids or an antihistamine. I would not, obviously, at least for my own personal practice, I wouldn't consider giving this, on the outpatient side if I didn't know how they were going to react at first. And obviously, it's always a good thing to pre-medicate if they're going to potentially have an infusion-related or injection-related reaction. Do not administer live vaccinations while on therapy and until B-cell repletion. Siponimod, or Mayzent. This one has come out in the last couple of years. It is a sphingosine 1-phosphate receptor modulator, singular to Fingolimod, or basically Gilenya. It prevents lymphocyte exiting from the lymph nodes. It is available PO. The dosing is very specific, and it will actually depend on the different phenotype of CYP2C9 that the patient has. That's all I want you to know in regards to dosing. Like I said, dosing is not important necessarily on the other medications, but all I want you to know here is that for Siponimod, it depends on the CYP2C9 genotype that the patient actually has. And the dosing regimen, there's actually, I believe, 2 dosing regimens for this specific medication. This medication is relatively new in the last couple of years. In relation to adverse effects, you see a lot of the same things that you see with Fingolimod. The one thing that's different, though, is that obviously with this CYP2C9 genotype issue of the dosing, one thing that's important to note is that it is contraindicated in patients with CYP2C9 3.3 genotype. If you have this type of genotype, you should not give this agent. In the last 6 months, they should not have had the following: MI, unstable angina, stroke, TIA, decompensated heart failure. Now, if they have any current MOBITs to 2nd or 3rd degree AV block or sick sinus syndrome, that's not, great either. You don't want to use it unless the patient has a pacemaker for sick sinus syndrome. Usually, that is the treatment of choice in a patient who has sick sinus syndrome, where they can go very bradycardic or very tachycardic, kind of at the drop of a whim. They will put a pacemaker in those patients to basically regulate the rate of the heart. Do not administer live vaccinations while on this therapy either. Ozanimod, or Zeposia, similar to basically Fingolimod as well. Sphingosine 1-phosphate receptor modulator, prevents lymphocyte exiting from lymph nodes. You're going to see a lot of the same stuff with this drug as well. It is available PO. The dosing regimen is very complicated. You have to basically be very cognizant of the dosing for this medication. They may actually have special dosing packs for the patients so they don't get confused either. Same thing in regards to relation to Fingolimod, more or less. The unique things here with this one is that considerations are severe untreated sleep apnea. That's a contraindication here, and MAOI usage. As Dr. Puzantian has probably alluded to prior in the neuropsych course, MAOIs are not used a lot clinically in practice for psych disorders anymore, as they have kind of fallen out of favor in regards to their side effect profiles and their interaction profiles. But occasionally you may have a patient who may potentially be on an MAOI, and that is something that still has to be screened for. So that is important to note, hint, hint, star, star. Do not administer live vaccinations while in therapy. Mitoxantrone, this one's typically known as a chemotherapy agent, but it can be used in MS as well. targets proliferating immune cells, inhibits proliferation, induces apoptosis of T and B cells, macrophages, and other antigen-presenting cells. IV. There is a maximum lifetime dose on this one. You don't need to necessarily know that for the purposes of this class, but you may need to know that eventually for your oncology course. All I would know here is that you need to check for max lifetime dose. That's all I would expect you to know here. Adverse effects, the unique things are menstrual disorders, obviously alopecia being a chemotherapy agent. It does color the urine blue-green, and as you see here in the vial, it looks kind of bluish, so that can be a contributing factor here. And arrhythmias and cardiotoxicity are also a problem, so you want to make sure that you obtain a baseline EKG and an echocardiogram to assess for any related heart failure. If you have a patient that has heart failure or arrhythmias, this is not a great drug to use. Considerations are it's pregnancy category D. You want to screen obviously prior to therapy start if the patient is of childbearing age, and we don't want to administer live vaccinations while on this therapy. Cladribine or Mavenclad. It's a purine nucleoside, may result in DNA synthesis shutdown, leading to B cell and T lymphocyte cytotoxicity. It is available PO. Dosing is relatively complicated here as well. There are basically 2 cycles per year that are given over a 2-year course. And then after that 2-year course is given, they say to basically take a break for at least 2 years after that you don't necessarily need to take it again, though it may be potentially given. Depends on, obviously a neurological consult, though. This is a newer drug, technically for MS, but it is used in the oncology world for other indications. Some adverse effects related to Mavenclad are decreased hemoglobin, thrombocytopenia, lymphopenia, infection, headache, and upper respiratory tract infection. This one is unique in that it is contraindicated in pregnancy, so obviously you got to screen for that prior to starting therapy. And it's also contraindicated in males and females who are capable of reproduction who don't intend to use birth control. So if you think about it, it's almost kind of similar in a way to the 5-alpha reductase inhibitors that we talked about in endocrinology in regards to reproductive potential. They can potentially be teratogenic to the fetus. And obviously, if you are a male and having intercourse, that can obviously cause problems if conception occurs, and can still be teratogenic to the fetus. This is contraindicated in patients with a current malignancy. We don't want to necessarily affect any kind of malignancy that they currently do have, because they might be undergoing other chemotherapy for that. It's contraindicated in HIV and other chronic infections like tuberculosis. May obviously, activate a latent tuberculosis to go into an active tuberculosis diagnosis. And then we don't want to administer live vaccination on this one either. So those are all the drugs. In terms of non-pharm therapy that we want to consider is obviously we want to make sure that the patient can, exercise appropriately. Anything that they can do to keep moving and keep, healthy is obviously something that we're going to obviously advocate for. We want to make sure that they can rest. They don't overexert themselves. If they need assistive devices like a cane, a wheelchair, whatever they need, a lot of times insurances will cover things depending on where the patient is at in terms of their disease progression and what their diagnosis is. Physical, speech, and occupational therapy are always important. So we want to obviously evaluate the physical and speech needs of the patient, but also occupational therapy. What will the patient need in regards to some of the non-pharmacologic needs? Does the patient need, ergonomic chairs to feel more comfortable? Do they need, an arrangement such that, they're, not climbing upstairs to go to a bedroom? Those are things that, may need to be potentially considered, and basically there might need to be solutions that need to be worked around for a patient. Treatment approaches. So as we kind of, alluded to earlier, it is not necessarily always a hard and fast thing of what is first and second line or third line or fourth line in MS. There's no perfect guideline per se. And head-to-head comparisons between different treatment options are very limited. Adherence to treatment is important. So if a patient stops taking their medication, that might result in them having more flares if it's a drug that reduces clinical relapse, or basically an exacerbation, or if they are taking, for example, Dalfampridine, and stop taking it and start having more issues walking. If you have an intolerability to a drug where a patient just can't tolerate the side effects anymore, you might be able to switch between agents, and that's perfectly acceptable. Obviously, a lot of these adverse effects, as we saw, are very nasty, and if they need to stop taking an agent, it's not necessarily something that you can convince the patient of otherwise. Sometimes it depends on what the best agent for that patient is. You may consider a second line agent as first line if you have rapidly evolving MS. And that's not just RRMS, but that can be, primary progressive. You might consider Ocrelizumab first line for PPMS, and that's fine because it is the one drug that is technically, FDA approved for PPMS. Consider off-label treatments if inadequate response to second-line agents. So like a lot of the other, agents that we talked about, Rituximab or Rituxan, not necessarily FDA approved, can be used for a lot of different things, but technically off-label. I don't necessarily want you to know what is on-label and what is off-label. I just want you to know basically what can be potentially given. You can always look up the FDA indication if needed later. But the one thing I do want you to realize is that obviously some of these drugs are indicated just for RRMS. Some of them are indicated for PPMS, obviously Ocrelizumab being one of the important ones. Again, hint, star there. And you may consider treatment of MS complications with non-pharma pharmacologic therapy. Spasticity can be treated with a lot of different treatment options like baclofen, benzodiazepines. You might want to treat the urinary incontinence of the patient with urinary incontinence agents. And obviously be cognizant with those urinary incontinence agents if your patient already has constipation, because obviously we saw that constipation as a potential, symptom of MS. So if you're giving a lot of the urinary incontinence agents, they're going to be very constipating. And that is something that you want to consider. You always want to consider risk over benefits with, your patient, and what is the patient going to be tolerable of and what will they not be tolerable of. These are the references for today's talk. And we're going to go back to the case questions. So we had a 36-year-old female, came to her physician for an annual checkup. She was diagnosed with MS 3 years ago after her second MS flare in 2 months. Following her MS flare, she had no other flares. Besides her 2 flares that she did have, she's had no other symptoms since then. Which type of MS does GT or the patient most likely have? The answer here is relapsing remitting MS. So remember that remitting basically means that they don't have any symptoms, or basically their symptoms basically kind of resort back to where they were before. And relapsing basically means that you basically have relapses or flares or exacerbations. Relapses, flares, exacerbations, all are similar terminology. And basically if you're having flares, obviously you have some type of relapsing physiology going on. Secondary progressive, we talked about, is basically very, very rarely diagnosed. It is basically a lot of times diagnosed after a patient's already been diagnosed with RRMS. Primary progressive, they basically start having symptoms and they just progressively get worse, but there are no flares or no MS exacerbations or relapses. And progressive relapsing is basically it gets worse and there are relapses. That is basically the way that you kind of determine which one the patient, has. And remember, RRMS or relapsing remitting MS is the most common type of MS that is seen in patients with multiple sclerosis. Second question is, the patient's multiple sclerosis has never been considered aggressively or mildly evolving by her physician. Which of the following agents may GT most likely be on considering her disease course? So the answer here is dimethyl fumarate or Tecfidera. Alemtuzumab or Lemtrada and Natalizumab or Tysabri are typically reserved for patients who are very poorly presenting initially, or they're considered generally second line. They're very much more aggressive therapy. Dimethyl fumarate can be considered a first or a second line therapy for MS. It has relatively good relapse reduction rate compared to some of the other agents that we see. Methylprednisolone is only used for MS flares, and because the patient hasn't had an MS flare recently, we wouldn't necessarily expect her to be on this agent. Last question, patient has, or which of the following agents may cause this patient to have bradycardia and AV block requiring cardiac monitoring after the first dose is administered? Answer here is for Fingolimod or Gilenya. Remember, this does have its own REMS program where they actually need to basically have the prescriber and the pharmacy registered for special monitoring. And usually with Fingolimod, they need to monitor for at least 6 hours after they give the dose. That is very, very, very important with this agent specifically. That is today's talk on MS. If you have any questions regarding MS, please feel free to email me. Thank you and have a great day. Bye-bye.